All of you, please mute yourself. Good morning, guys. Today I'm going to talk about the rest of the type of osteomyelitis. In the last time, we talked about acute osteomyelitis. So today, it's turn for subacute as well as chronic osteomyelitis discussion. Now, according to the definition, which we have discussed in the last class, subacute osteomyelitis means when the clinical features remains there or when the pathology extend more than 2 weeks. To be very precise, 2 to 3 weeks. Okay, if it remains 2 to 3 weeks, then this is subacute. If it remains more than 3 weeks, it is called chronic osteomyelitis. But practically, okay, acute is up to 7 days, subacute 7 to 14 days, and more than 14 days or 2 weeks is called chronic osteomyelitis. So that is very well known to everyone. Okay, so with this, let's enter into the topic. So this subacute osteomyelitis has an insidious onset, mild symptom, and there is a usually lack of systemic reaction. Means the person doesn't have fever, the person doesn't have high grade fever there and other systemic reaction. They just have some local problem in the bone. Its relative mildness is due to less virulent type of organism, patient become more resistant, or combination of both, isn't it? We have to think why some of the patient develop serious symptom, why others develop milder type of symptom. Probably it is their immunity which is playing a role there. And another important point is the bacteria probably are less virulent than the acute variety. Now, the most common site for the development of subacute osteomyelitis are distal end of the femur, proximal end of the tibia, and even the distal tibia. So sites are a bit similar with the acute osteomyelitis. Regarding the pathology, typically there is a well-defined cavity formation in cancellous bone. Okay, cancellous bone is present to the near end of the bone. So usually in the tibial metaphysis that is present. Now, it doesn't usually contain pus, but in the place of pus, okay, in the place of pus, it has some viscous, slimy, seropurulent type of fluid. So this is one of the important points regarding subacute osteomyelitis. The cavity is lined by granulation tissue, okay, which contains a mixture of acute and chronic inflammatory cells. You all know what are these cells. Acute inflammatory cells are neutrophil, and chronic inflammatory cells are, what are the chronic inflammatory cells? Yes?
Lymphocyte macrophage.
Lymphocyte macrophage.
Excellent. Lymphocytes and macrophages, they are the chronic inflammatory cells. So this is somewhere in between the acute phase and the chronic phase. That's why there is a collection of both type of inflammatory cells. The surrounding bone trabeculae are often thickened because of the chronic reaction, and sometimes it may encroaches on and erode the bony cortex. Okay, it may go a little bit superficial, and it may erode the bony cortex also. Occasionally it appears in the epiphysis and in adults in one of the vertebral bodies as well. Now let me repeat again. Mainly it is found in metaphysis. Metaphysis is between the epiphysis and diaphysis. So very rarely it occurs in the epiphysis, that means exactly at the end of the bone, or in the adult it may develop in the vertebral bodies as well. What are the clinical features of subacute osteomyelitis? Let's talk about it. There is local pain in the bone. The affected area will have local pain, and that pain may last for several weeks or months if we do not treat. If we do not treat, remember. There is a limping because of the pain. Patient cannot walk properly, or patient walks with pain. Swelling and local tenderness are present. Muscle wasting is present, because if we do not use that limb or that joint for a considerable period of time, the muscle are wasted in that part. This is a very well-known feature. And body temperature is usually normal, means there is no fever in the patient. Now, regarding the investigation, we have to take the X-ray of the affected part. Okay, and one of the differential diagnosis you need to think when we take the X-ray is osteoid osteoma or malignant bone tumor. Osteoid osteoma or malignant bone tumor. Now, osteoid osteoma is a type of benign bone tumor. Okay, and it may exactly looks like subacute osteomyelitis. So that's why it may be confused. But all those classical clinical features of inflammation will be absent there. And malignant bone tumor, the important one is osteosarcoma, which may occur at the same site. Biopsy is the confirmatory one. Fluid aspiration and culture has to be done. Remember, there is no pus, but there is some slimy gelatinous type of fluid. There will be raised ESR and WBC count may be normal because there is no systemic features. It is not a very serious type of disease for the patient overall. It only may damage the bone. So WBC count is not that high in this case. Now we are reaching to a very important part of this class, important slide you can say. When we check the X-ray, okay, there is a finding that is known as Brody's abscess. Brody's abscess. Now, what is this Brody's abscess? This is a circumscribed round or oval cavity formation, in those typical area which we have just, talked about, like the lower end of the femur, upper end of the tibia, and sometimes the lower end of the tibia as well, especially in the metaphyseal area. So circumscribed round or oval cavity around 1 to 2 centimeter in diameter, usually in those area, okay, may be a case of Brody's abscess. It may occur rarely in epiphysis, cuboidal bone, or even in calcaneum. Now, this cuboidal bone and calcaneum are present where? In which part of our body? Yes, where are
In
they?
the lower limb, tarsal bone.
Exactly, very good.
Tarsal
They
bone
are
Lower limb.
clearly.
very good. So they are, tarsal bones. They are the example of tarsal bone. They are present in the lower limb. Excellent. So they can be affected and they can have Brody's abscess sometimes. The metaphyseal lesion cause no or very little periosteal reaction. Okay. The periosteal reaction, which is increase in chronic osteomyelitis and even in acute osteomyelitis, it is not much here. The diaphyseal lesion means shaft lesion may be associated with new bone formation and marked cortical thickening. But in the metaphyseal and epiphyseal area, it is not commonly seen. Let's look at the picture, then you will be quite clear about it. All of you, please focus here. You can nicely see a cavity there. See there? Look at this area. Okay, this is a cavity which is present at the upper part or upper end of the tibia bone. So this is the Brody's abscess. So it's a circumscribed oval cavity surrounded by a zone of sclerosis. Look at a little bit thickened bone there, okay, at the proximal tibia. So this is a case of Brody's abscess. This is a lateral view X-ray of left tibia and fibula. There is a marked periosteal reaction at the diaphysis. Let's look at this area now, exactly at this side. See how thick it is. It looks a bit irregular also. So this probably is the normal appearance of the tibia, and here it's swollen, means excessive bone has formed. And why I know this is a bony appearance? See how dense it is in the X-ray. It looks very dense. So this is a new bone formation here. Look at these other X-rays now. Okay, so see here. So these are the different bony cavities I can see inside the bone. See there. This is another one. Okay, here is another one. So clear-cut cavity-like appearance, surrounded by very less periosteal reaction. Very less. This is the important point in Brody's abscess, especially if it is present around the metaphysis or epiphysis. Very little or no periosteal reaction. So let's talk a little bit more about this, or a little bit revision also for you. See there, those who have suffered from bone infection for several days will start to exhibit bone reaction and destruction at the same time. Now, destruction will occur a little bit earlier than the bone reaction. Bone reaction means new bone formation. On plain radiograph, a new periosteal reaction with a fluffy margin is typical of Brody's abscess or subacute osteomyelitis. If we go for ultrasonography, it will show increasing soft tissue edema and subperiosteal fluid because of the reaction of that infection in the surrounding area, So this type of features is developed. X-ray cannot pick that, but X-ray will slightly show the change in density, but ultrasound is a good investigation for that type of finding. Now, these days, okay, MRI is the most sensitive technique as the marrow changes predominate in the early phases of subacute osteomyelitis. So routinely, MRI scanning is done in this type of cases. CT scan and ultrasound have limited role. Ultrasound will only show if there is a affection of the subperiosteal area or soft tissue edema, which is surrounding that area. Okay, so let's move on. Now, see that there is one important MCQ question which may be asked to you, okay, in your future orthopedic exams. If we do MRI in case of subacute osteomyelitis, then there is a penumbra sign which may be seen. This is known as penumbra sign. This is usually seen in T1 weighted spin echo image. So now see this. This is called penumbra sign. Okay. Penumbra sign, and this is surrounded by a bit of fibrous rim-like structure. So this whole appearance is called penumbra sign here. So see this. So this is a calcaneus bone. You all know. See that this is a heel. This is the lower limb or foot area. So calcaneus. At the center, okay, there is a destruction of the bone. This black area is a bony destruction. This is surrounded by a halo. This is a halo. Okay, we call it penumbra sign. This halo is formed by granulation tissue and edema, or sometimes even by slight bone reaction also. So this penumbra sign represents a rim of vascularized granulation tissue around the bone abscess cavity that has a higher T1 weighted signal intensity than the cavity itself. So just know that much. This typical type of appearance is called penumbra sign. Okay. The penumbra is iso-intense to the muscle on T1, enhance on contrast administration, and is hypo-intense on T2. Now, these are different, types of the MRI. T1 weighted image, T2 weighted image. Probably you have studied in radiology. So in T1 weighted MRI, it looks, iso-tense to the muscle, iso-intense, I should say. The density looks similar to the muscle. That's the meaning. Okay, and hypo-intense means the density looks lesser than when we compare with something. That is the meaning. So let's move on. Now, how we treat? This is a case of infection. So, okay, and a little bit of chronic type of infection. It is going towards the chronicity. Though according to the definition, it is somewhere in the middle, but still we take it as a type of, chronic osteomyelitis regarding the treatment. Okay, regarding the treatment. Now, what treatment we are going to do? One type is conservative treatment, another is surgical. Now, conservative treatment is done by immobilization and use of antibiotics. The common antibiotic which we use are flucloxacillin and fusidic acid for 6 weeks. Now, can you tell me these antibiotics are used for which organism? Yes? Which organism?
methicillin sensitive Staphylococcus aureus, sir.
MRSA.
Excellent answer. Very good. Very nice. You can simply say they are used for staph aureus, but if you add methicillin sensitive staph aureus, that's even better, because if staph aureus is methicillin resistant, we have to go for vancomycin. These antibiotics do not work. So you already know the commonest organism here is again Staph aureus. Regarding the surgical treatment, okay, we have to go for biopsy, but it is a type of investigation rather than surgical treatment, and it is done only if the diagnosis is in doubt. And the treatment here is curettage of the lesion, means we curate that affected part of the bone, along with antibiotics, definitely. Now, with this discussion, let's enter into the chronic osteomyelitis topic, which is very related to this whole mechanism. There, for example, why I'm saying this: if a patient develops acute osteomyelitis and if we do not provide the good treatment, then the same patient may convert into subacute or chronic osteomyelitis as well. That's why they are related things. Now, chronic bone infection or chronic osteomyelitis usually result from inadequately treated acute osteomyelitis or from infection following compound bone fracture. Compound bone fracture. You have done that before. This is an open bone fracture. Okay, the fracture site is visible from outside, and there is a high chance of contamination. That area can easily turn into osteomyelitis, and later on again into chronic osteomyelitis. So according to the duration of the sign and symptom, practically more than 2 weeks, okay, and according to different literature, more than 3 weeks. So anyway, you can answer regarding chronic osteomyelitis. Now, please pay attention. This is a very important concept, and it will provide you a little bit revision again. What is the pathogenesis of chronic osteomyelitis? See here. If acute osteomyelitis is inadequately treated, if there is an infection of foreign implant, or if there is open fracture and later on if it develops infection, they are the start point for chronic osteomyelitis. That's how the disease start. The inflammatory process, okay, continue with time together with persistent infection by Staphylococcus aureus. We already know that. That is still the commonest organism. Now, that persistent infection in the bone, which is seen in osteomyelitis, leads to increase in intramedullary pressure due to pus formation, which will cause stripping of the periosteum. Now, what is happening here? There is a area of infection, and in that area of infection, there is increased pressure development because of the pus formation or in the initial period exudation. Now, that will, cause increased pressure everywhere in the surrounding area. Now, what will happen? The pus may move towards the periosteum and it will elevate the periosteum from the surface. This is called stripping the periosteum. Okay, this is a very important part of the pathogenesis. Now, there will be formation of vascular thrombosis. Thromboses are quite common because of infection. Now, remember, whenever infection occurs in a particular area, whatever blood vessels are there, the wall of those blood vessels are also inflamed. And that inflammation results in thrombus formation. After vascular thrombosis, there is necrosis of the bone or bone death occur. And that bone or dead piece of bone is called sequestrum. At the same time, because of this periosteal reaction, there is new bone formation, which is known as involucrum. Okay, it has the same term which we have discussed in acute osteomyelitis. Sequestrum is the dead bone, involucrum is the new bone formation. And the important point is still there. Multiple openings appear in this involucrum through which exudate and debris or the pus, okay, from the sequestrum pass via the sinuses. And sometimes even the pieces of sequestrum come outside. Now, this is called cloaca. Cloaca, we have already talked about this. And this sinus or cloaca is one of the hallmark of chronic osteomyelitis. Okay, so this is about the pathogenesis. So let's move on. Now, let's talk about something else. Okay, how we stage this chronic osteomyelitis, how to do the staging. Now, this is done by Cierny-Mader staging system. This is quite easy actually. Just focus here. According to the lesion type or according to the worst category, this staging or classification is done. Stage 1 is medullary, stage 2 is superficial, stage 3 is localized, stage 4 is diffuse. Okay, so according to the affection of the bone, this type of staging or classification is given. So medullary, right at the center of the bone, medullary cavity. Superficial, okay, towards the periosteal area, the cortex and the superficial part of the cortex as well as periosteal area. Localized in one area of the bone, and diffuse, the multiple areas of the bones are affected. Regarding the host category, type A, the normal, means the normal immunity. Type B, compromised by local or systemic condition. And type C, severely compromised by local and systemic condition. Means there is some predisposing factor already present in the patient. Now, let's move on to the clinical features of chronic osteomyelitis. So what, we see if we examine the patient, and what are the symptoms the patient will present to the hospital. The patient present with pain, okay, at that site, pyrexia or fever, redness and tenderness at that site again, or with a discharging sinus. So these are important points. This redness and tenderness and excessive pain occurs, okay, when the infection flare up. And sometimes what we say, remember that sometimes the acute infection may occur on a setting of chronic infection. This is known as acute on chronic infection or acute on chronic osteomyelitis. So during that time, all the clinical symptoms and sign will be excessive. In long-standing cases, the tissues are thickened and often puckered or folded inward, where a scar or sinus adheres to the underlying bone. Means it looks a bit of puckered appearance there. Something is deeply attached to the underlying bone. There may be a sinus formation, there may be a scar, because this is a chronic infection. So all of these features can be seen. There may be a seropurulent discharge and excoriation of the surrounding skin because of the constant drainage of the discharge from the sinus. Okay, the surrounding skin is also developing some excoriation or some of the clinical feature. Now, one small question I like to ask you: there is a scar formation here. You can clearly see. See this? There's a scar, right? If a type of malignancy develops from this scar, what we call that malignancy? If malignancy develops in this scar, what is the name we give? Anyone?
Osteosarcoma.
Osteosarcoma.
No,
Osteosarcoma.
no. Osteosarcoma is a different. Osteosarcoma occurs inside the bone. But what I'm saying here, if a scar is formed on the skin, okay, or in the superficial part of the chronic osteomyelitic area, and
Keloid formation.
if a malignancy develops there, that is a type of malignancy. What is the special name of that malignancy? Anybody? Okay, so it is a bit of a difficult question for you probably. So let me answer this. That is a type of squamous cell carcinoma. Okay, squamous cell carcinoma. It is known as Marjolin's ulcer. Marjolin's ulcer. Okay. It looks like an ulcerated appearance. But if you take a biopsy from there, it's a type of squamous cell carcinoma. And this is known as Marjolin's ulcer. Small, information which may be very, very important from the, MCQ point of view. Let's move on. See this. So look at this different types of picture here. This doesn't look good at all, isn't it? See this. The whole soft tissue is visible. The skin is lost there. Okay. So probably this may be a case of, a compound fracture or open fracture, and secondarily, there is a development of osteomyelitis. There is a long suture also, you can see there. Okay. Long suture also. See there, I can see the piece of bone there. This may be, a new bone formation there, okay, called involucrum. And there is a very, ragged area, very irregular looking area. Look at the skin. Look at the reaction of the skin, which is surrounding. So all of these are quite typical of a chronic osteomyelitis. Now, this is a schematic diagram, which is very useful for you to understand the concept. Here, the chronic osteomyelitis involving the metaphysis of the tibia is shown as a schematic diagram. This is the skin. Okay, it's a subcutaneous tissue. There is a periosteum of the bone. Okay, and this is the upper end of the tibia. See that there is the epiphysis of the tibia. You can see. So in this this area is the metaphysis. In metaphysis, there is a development of a cavity. Okay, so this is a dead bone, which is called sequestrum. There is a formation of draining sinus, and through that sinus, the secretion is coming out. Okay, the pus is coming out, and this pus will cause some reaction on the tissues also. And over a period of time, this tissue will also develop some reaction, the soft tissue as well as the skin. And sometimes even the pieces of dead bone may come out from this area. Now, there is a sequestrum, and that is the involucrum. It is very difficult to identify from this type of view. Okay, and we don't ask this type of question also to you. We just ask what is the name of dead piece of bone and what is the name of new bone which is formed there. So every students are quite familiar to that now. And more important is a X-ray appearance. X-ray appearance. Sequestrum and involucrum. I already asked this question in the last class. Sequestrum is a dead bone. So that dead bone cannot be resolved because of the lack of blood supply. So it looks more denser than the new bone there. Okay, don't forget that. And this is another picture of chronic osteomyelitis. Now, with this a little bit, description regarding the imaging. What are the important, imaging we do in case of chronic osteomyelitis diagnosis? X-ray is done first because it is very easy type of investigation and easily available also. It usually show bone resorption either as a patchy loss of density or as a frank excavation around an implant. Now, if this implant is infected, and definitely in that area there will be bone infection. And remember, if this implant is infected, we need to take it out. Now, implant means we are talking about open reduction and internal fixation, like screws, nail, okay, rod, isn't it? All these are called implant. So if they are also infected, then that may be a case of chronic osteomyelitis. There is thickening and sclerosis of the surrounding bone. CT and MRI are invaluable in planning operative treatment. Okay, so they are usually done. Before the treatment. Together, they will show the extent of bone destruction and reactive edema, hidden abscess, as well as sequestra, and they will help us to confirm the diagnosis and to plan for our treatment also. Now see here, once again, a similar type of picture, which is very informative for you, though this is a, see there, it taken from this, applied radiology, but it is very useful right at this context. There's a ring sequestrum formation. It looks like a ring. A sequestrum is a piece of dead bone. So it is surrounded by involucrum, okay, involucrum. So this all thing is involucrum here. It is formed by periostal reaction. Sequestrum is a dead piece of bone right here at the center. This one, okay. There is a cloaca. Cloaca is a discharging sinus. which formed there, and there is a pore union. Okay, pore union, because this is infected area. If there is a fracture occurs, then there is a very pore union. Fracture doesn't heal in the presence of infection. See there, this area, okay, is affected, and here this area is affected. Now, why this area is affected? Because it looks quite patchy. Okay, there is a loss of bone density at the center, surrounded by a little bit high density bone. So this is a reactive bone formation. You understand like this. There's another picture. See this. There's a nice cavity looking appearance, which is surrounding by sclerotic bone. And here in this area, this whole area from here to here. See this. Okay. This must be a piece of sequestra of the dead bone. And involucrum are always present on the site. So dead bone and involucrum. These are a patchy, okay, destruction of the bone. So to summarize, okay, chronic osteomyelitis is all about the presence of sequestrum and involucrum. Sequestrum is a piece of dead bone which is present right at the center, surrounded by a periosteal new bone formation which is known as involucrum. Look at the density there, okay? You can clearly see. Now, finally, what is the treatment now? What type of treatment should we provide, okay, to a patient of chronic osteomyelitis? The treatment is mainly surgical here, though we definitely give antibiotics, but treatment is mainly surgical. We need to go for bone debridement. We need to remove that dead piece of the bone, all those dead and devitalized tissue from the bone. The goal of debridement is to leave healthy and viable tissues. Debridement of bone is done until the punctate bleeding is noted, giving rise to the term the paprika sign. Now, this type of questions can be asked in the exam. So what do you mean by that? Debridement of the bone is continued until some punctate bleeding is noted, means some healthy tissues are there. Then only the bleeding can occur from there nicely. So this is known as paprika sign. And the surgeon knows, yes, I have done enough debridement. Okay, now a good cavity is already made. So this is how the debridement is done. It is a bit similar. I want to compare this with, burn case, with the case of burn. A similar type, we remove that scar in case of burn, okay, till a nice or good type of bleeding occurs from the area. Now, some other types of treatment in case of chronic osteomyelitis are, see there, these are the important terms for you. Sequestrectomy is a removal of sequestrum or the dead bone. Saucerization. Saucerization means because of the surgical debridement, you are converting that area into a nice cavity. Okay, a big cavity is made first because this is necessary. We need to remove all the dead and devitalized tissue from there. Okay, so this is known as saucerization. And later on, if this cavity is quite big, you need some bone chips, okay, to fill that area. This is called bone graft. This is called bone graft. And sometimes even muscle pedicles are necessary there. But the real meaning of saucerization is extension of the surgical debridement and converting that area into a nice cavity. Curettage is done to remove all those, abnormal types of tissues. After that, we go for cancellous bone grafting. Just now, I talked about it. Okay. Proper analgesics are necessary. Proper antibiotics are very important, and immobilization of the affected part is also quite necessary regarding the treatment of chronic osteomyelitis. Now, which antibiotic you are giving here? Which antibiotic? Any idea? Which one?
Broad spectrum.
Like which organism you want to cover there? This answer is
Staph aureus, sir.
Staph-
Tetracycline, monoglycoside, we can use.
Exactly.
Streptococcus,
Now see there.
Marsal.
Now this is a case of osteomyelitis, and you know the most common organism is Staphylococcus aureus. Okay, so focus on that organism first. Focus on that organism. So you can use flucloxacillin, okay, a fusidic acid, those type of antibiotics. But if it is a hospital acquired type of infection, then I can not take those chances. I can straight away go for vancomycin. This is one good way of answering. Another one, if a compound fracture is secondarily infected, then probably there will be multiple organisms, not only Staph aureus. Then during that time, we can say broad spectrum antibiotics to cover most of the organisms are used. So see there, so you are giving a good reason for the use of antibiotics here. Now see this, a little bit of description of sequestrectomy and saucerization. Sequestrectomy, removal of sequestrum or a dead bone. A window is made in the overlying involucrum and the sequestrum is removed. So this is sequestrectomy, removal of sequestrum. Whereas saucerization means the bone cavity is converted into a saucer by removing its wall, and it allows free drainage of the infected material. So we convert that cavity into a bigger cavity, and then we also remove the superficial part of this, means the cavity is kept open so that it can nicely drain outside. So this is done because this is a chronic type of infection. Curettas, we already know, we curate, okay, the infected granulation tissue and the dead piece of the bone also. Sometimes they are small pieces, we can remove them as well, okay. And excision of an infected bone can also be done. If it is extended, here and there, a little bit upwards or downwards or in the surrounding area, then you can do that as well. These are the different types of treatment. Now, amputation is very rarely done. Okay, very rarely done in case of chronic osteomyelitis. Sometimes it may be necessary, especially if there is a malignant change, okay, in the discharging sinus. Even amputation is necessary. And in many cases, combination of these procedures are done. So this is how osteomyelitis is, or chronic osteomyelitis is treated. I'm sure you know the meaning of amputation, right? What is amputation? Yes? What is it?
Removing the affected area of the limb.
Cutting affected part of the.
Exactly. You excise or cut that affected part of the limb. Okay, that is called amputation. This is considered as a very, you know, this is not good type of treatment for the patient. The quality of the life will severely hampered because of amputation. So as far as possible, we don't go for this. But sometimes we need to go for it, if there is some malignant change. So the decision is difficult here. Finally, there are different types of complication. Okay, just go through it. It is easy for you to understand. Pathological fracture, because the bone is weakened by chronic osteomyelitis or formation of the bone cavity. Deformity may occur because of the destruction of the epiphysis growth plate in case of child. Okay, the growth plate is destroyed, so there will be no growth of the bone. Number one. Even if the growth occurs, it may be a bit deformed type. Shortening and lengthening of the bone occur. We already discussed this in the last class also. Destruction of the growth plate, complete type of destruction will arrest the growth. But because of the hyperemia, because of the increased blood flow, there is stimulation of the growth plate, which can result in lengthening of the bone as well. Some other complication you can add there, like a Marzollin's ulcer formation, because that scar, that sinus, it can convert into a squamous cell carcinoma that is known as Marzollin's ulcer. Okay, so all these things you can add there. Now we're talking about different types of chronic osteomyelitis. Now, one of the important type or a subset, we should say, of subacute chronic osteomyelitis is known as GARRE'S sclerosing osteomyelitis. Now, sometimes it can be asked as a question in the exam because it is a bit of atypical. Okay, it has features a bit different from the common type of osteomyelitis. Okay, so let's talk about it. Garre in 1893 described a rare form of non-suppurative osteomyelitis, which is characterized by marked sclerosis and cortical thickening. Now, this is a clear-cut picture of Garre's sclerosing osteomyelitis. There is no pus formation, number one. There is a marked sclerosis and cortical thickening around that infected site. This is the hallmark of Garre's osteomyelitis. So there is no abscess cavity or no abscess or no pus formation, only a diffuse enlargement of the bone at the affected site. And that affected site is usually the diaphysis of one of the tubular bone or the mandible. It may be, shaft of the tibia, it may be shaft of the femur, or it may be the mandible. The patient is typically an adolescent or young adult with a long history of aching and slight swelling over the bone. So there is a bit of pain and swelling over the affected area of the bone. Occasionally, there are recurrent attacks of more acute pain accompanied by malaise and slight fever. So this is clinical feature of Garre's osteomyelitis. Now, the more important points here are the differential diagnosis and radio diagnosis. Now, please pay attention here. See this? X-ray, if we do, it shows increased bone density and cortical thickening. In some cases, the marrow cavity is completely obliterated. It is completely blocked because of excessive cortical thickening of the bone. So this is the hallmark of Garre's sclerosing osteomyelitis. There is no abscess cavity or no pus present inside the bone. Diagnosis can be difficult sometimes because if a small segment of the bone is involved, it may be mistaken for an osteoid osteoma. Okay, osteoid osteoma, and if there is a marked periosteal layering of the new bone, then we may be confused with Ewing sarcoma. Let me clarify this for you. Osteoid osteoma is a benign tumor of the bone. So I will talk about the bone tumor class later on. Okay, after I do this, probably in next few classes, then we classify the different type of bone tumor. Some are benign, some are malignant. This osteoid osteoma is a painful condition in the bone. This is a benign. And Ewing sarcoma is an important type of malignant bone tumor. The hallmark of Ewing sarcoma is it has a small blue rounded cells, and it looks like there is an onion peel-like appearance because of the marked periosteal layering of a new bone. So this is why it is confused with Ewing sarcoma. So how to distinguish them? We need to take a biopsy. The biopsy will disclose. Okay, the biopsy will show. Okay, wait. Let me underline this for you. The biopsy will disclose a low-grade inflammatory lesion with reactive bone formation. And there are no malignant cells, definitely, because this is Garre's osteomyelitis we are talking about. Microorganisms are seldom cultured, but the condition is usually ascribed to staphylococcal infection. Though the microorganisms are not, commonly cultured from there because the grade of infection is not that much, but it is thought to be because of staphylococcal infection, just like any other bony infection there. So what is the treatment now? Just like any type of chronic osteomyelitis, the operative treatment is commonly employed. The abnormal area is excised and the exposed surface is thoroughly curated. All those affected area should be curated there. Bone graft, bone transport, or free bone transfer may be needed. Usually the bone grafts are done, which are taken from iliac crest. So this is the treatment of Garre's osteomyelitis. Now at the end, let us see some of the X-ray, how it looks. Okay, let's move further. See there. There is Brody's abscess. Okay, see this? Why it is a Brody's abscess? Because I can see the cavity there. Cavity is very nicely seen. This is a cavity. So it is a Brody's abscess. And the typical site for Brody's abscess is upper part of the tibia. Okay. Now look at here. I cannot see any cavity here. Okay. It looks like small, cavity-like appearance, but there is a marked thickening. Okay, marked thickening of the bone. So it is a bit of confusion. Okay, between Brody's abscess and Garre's sclerosing osteomyelitis. Now, what are the differences here? If the clear-cut cavity is seen, okay, if we can aspirate pus or some gelatinous type of material, mucopurulent material, it is Brody's abscess. In Garre's sclerosing osteomyelitis, there is no pus or no collection there. Okay, so we can go for those type of tests if we are confused. Now, see this? Okay, it may be confused with this a bit of cavity, but rather than that, the extensive reaction of the bone is there. So I will label this as a Garre's osteomyelitis rather than Brody's abscess. But here I can see the cavity. See this? There is a rim of the cavity I can see. So this is Brody's abscess. The important picture which may be asked in your different exam is this mandible. Okay, the picture of the mandible. This is reactive bone formation in the mandible, a typical Garre's sclerosing osteomyelitis. So with this, okay, I have concluded the discussion on subacute and chronic osteomyelitis.